I'd like to now move to our next segment, and this is really what I would call a marriage of this molecular testing algorithm that we've talked about with the treatment-making process, or the decision-making process. And I'd like to start with a question to Anne. There'll be a series of questions here that are really centered around individualizing treatment. And the first one I would like to ask is, in 2013, is it still important to histologically subtype non-small cell lung cancer in this era of molecular testing?
Oh, absolutely. I mean, for right now at least, you have to know the distinction between adenocarcinoma and squamous cell carcinoma because of our treatments and what's available. Maybe one day in the future, molecular phenotype is going to predominate everything, but we're not there yet, and we probably won't be there for at least a decade. And so it's absolutely crucial to still have our pathologists get adequate tissue and make that distinction between the adenos and the squamous and the neuroendocrines also, because there's a huge spectrum of neuroendocrine carcinoma as well. And we don't have worked out as well in squamous cell carcinoma and neuroendocrine carcinomas, the molecular phenotypes. So until that day, I think it's absolutely essential.
Well, I think that's an excellent point, and I think also, as we know, it's not only what you should use, but maybe what you shouldn't use. We don't use bevacizumab, for example, in a patient with squamous cell carcinoma. Mark, how do you look at histology now?
I think exactly along those lines. I think we, our clinical behavior and therapeutic direction is so different based on what I like to call the squamous and the non-squamous in terms of our molecular testing, as we've talked about, but also the choice of agents. Bevacizumab, pemetrexed, options for non-squamous, but really not best options for patients with squamous histology. So I think that those are the major reasons why I agree with Anne, that I think for the near future, which is, in my opinion, going to be at least 10 years, we're going to be relying on our pathologist to make that distinction. I've said in many talks that I kind of believe that in many ways non-small cell lung cancer has become like non-Hodgkin's lymphoma. It's an architectural diagnosis, and so we need to give our pathologist adequate tissue to kind of make that distinction, because we've done some work where we've pointed out that although there's very good agreement amongst pathologists between small cell and non-small cell, there's much less agreement amongst pathologists between squamous and non-squamous. And so our pathologists need to do a good job at distinguishing that, but we have to get them adequate tissue so they can distinguish it.
I think this has been governed by the evolution in our therapies. The previous approach was sort of a one-size-fits-all strategy. The pathologists didn't really think it mattered, and they were right. If it was non-small cell, treatment was pretty much identical. But at first tier of testing, we need to know histology, and frankly, histology, to a large extent, as we've all pointed out, will then govern our molecular testing.
Yeah, and because of that, my thinking is that we've trained a couple generations of pathologists that were trained to say all the clinicians really want to know, is it small cell or is it not small cell? And they won't ask you if it's not small cell what it is. And then all of a sudden, because of this guy, we say, well, now we want to know if it's squamous or non-squamous because of bevacizumab. And that's what really started the whole histology thing.
This discussion brings up an additional point, and that is the recent data that have emerged about the genomic complexity of lung cancer, which is quite different from some of the other cancers, childhood cancers, or even acute leukemia in adults. For example, in non-small cell lung cancer of the adenocarcinoma subtype, the average number of mutations per megabase of DNA is about 10, and it's about 8 for squamous cell cancer. But the mutations and abnormalities are different. So this is a very complex disease, and that means that not only do we have inter-patient heterogeneity, but intra-patient, and that allows us to then think about how, in a Darwin sort of evolution, how these additional oncogenic drivers could come out. And also in the future, how we might be using next-generation sequencing instead of a panel of 10 mutations to test for patients. Are any of you using next-generation sequencing at your institutions for therapy decisions?
Well, we are for therapy decisions, as would be based on, of course, if you have the EGFR mutation, the known actionable agents, but we also, or targets, I should say, but also for the clinical trials. We're now part of the Lung Cancer Mutation Consortium, so there's clinical trials that are available for that. But I think that the other point that I would make is it makes you wonder just how naive we are thinking that one targeted agent, how much we're going to get out of it. And as wonderful as they do, they're limited in terms of how long that lasts. And so it's really no surprise given the information that we're hearing from either genomic analysis or mutational analysis, et cetera.
Mm-hmm.
I mean, I think you know, one of the issues is our scientists have evolved much to a much greater degree than we have as clinicians to be able to offer therapies that we know are going to work. For instance, what we're doing now is we'll do our initial panel of 8 genes, and if we don't find anything, we'll subject the sample to the ion torrent platform. And the first sample that I got back showed a p53 mutation, as well as a mutation in the VEGF receptor 2. And so that was kind of interesting. I don't quite know what to do with that, but it brings up some possibilities in terms of what you might think therapeutically. As we know, the VEGF TKIs have some activity based upon the response rate in this disease, but we don't know how to select patients. So I've filed that away as something that was found with kind of you know, more testing. But you know exactly what to do with that, and certainly what to do with p53, I think is you know, we have no leads there.
But it's all part of the information gathering pool.
Mm-hmm.
Right now we have a 46 gene panel that we utilize, and the goal is to have a 500 gene panel next year and then a 5,000 gene panel the year following. So Mark's absolutely correct. Our scientists, our basic scientists, are really moving fast on this technology.
And so we know what to do with all of those genes except
no,
4,900.
It's all information that we gather. I totally agree with you. Sometimes I look at what my patients have. They have very rare mutations like SMO. I had a gentleman with SMO the other day. What do you do with that? But you file it away because you don't know when we might have something for that patient.
You file it away, but I think you also need to manage expectations. Patients hear about this in the media, in the news. They think the next big thing has arrived, that there's immediately some agent that's going to be available that will target one of these obscure pathways. And we have to be careful about all of this. And we file it, we have it in hopefully an easily accessible biospecimen data bank that they can then go to when the proper agent comes along. The other point that Alan has made, particularly for those that aren't necessarily a specific oncogenic driving pathway, we're going to be looking at multiple agents targeting different pathways. And I think that's ultimately some of the evolution that's coming up. Just as we've used multi-agent chemotherapy, we'll be using multiple targeted agents.
But, you know, but getting back to David's point, I mean, part of this next-gen sequencing, looking at non-small cell lung cancer patients who are heavy smokers versus those that are never smokers. It's almost like it's a different disease in never smokers with regard to the nature of the mutations and the frequency of the mutations compared to a heavy smoking population. So the challenges are seemingly formidable in many patients as how could you target, and which mutations are important in driving the disease is another issue.
Absolutely agree. I think there are multiple different cancers that all fall under this rubric of non-small cell. Radiographically, they may look similar, but they behave differently. The phenotypes of the patients are different, and obviously they're going to require different treatments.
How I explain this to my patients is I use the analogy of a bus, and there are 30 passengers, and there's one driver. And so when I tell them about the molecular testing, I say, we're taking a look at all the people in this bus. We want to find out who the driver is. And at some point, the bus may stop, and they may change drivers. And in that case, we go after the new driver. But I think that's a way patients can identify with this.
I use the bus analogy a lot too, actually.